What my plan is today is to see if we can press to finish this and GU today, to give you guys a little bit more time with the material coming into this week. So just to make sure we're back kind of into this realm of pediatrics, kind of what we were talking about, to kind of think germ but for peds. So the stuff you were learning in germ, but now in this way. What do you treat and how do you treat perianal dermatitis in a child? Amoxicillin. What dose? 50. Why? Because it's curve-based drug. Yep. If I talked about a dome-like umbilicated papule, what's your diagnosis? Yep, molluscum. If you had to do monotherapy for acne, what would you say? Retinoid. Is poison ivy a contact dermatitis that's an irritant or an allergic contact dermatitis? Allergic. If I told you an infant had satellite lesions, what would your diagnosis be? Candida? Yep. If you had weeping and punched out lesions over an area of recurrent eczema, what diagnosis should you be thinking of? Weeping, punched out lesions on an area that's already got eczema, atopic dermatitis. Not staph, so the specific that punched out looks like you took a hole punch or two. Not varicella, but in that same realm, it's another virus. Herpes, yep. Eczema herpeticum. How do you treat that? Oral. So, acyclovir or valacyclovir. If you were going to do a bleach bath, how much bleach would you use? Quarter cup, we got that one. Why? Why are you doing a bleach bath? Kills off staph. Yep. So anything you're trying to do that for. So you could use it certainly if you had ringworm going on. You could use it most often for an atopic dermatitis. But as I told you the other day, I'm so excited to get to talk to you guys about poop today. Because poop is a huge deal in pediatrics. And so we're going to talk about it because we have to be on the same page. Because if you just talk about poop and we're not on the same page, we get all over the place. So, did you guys learn the Bristol stool? Let's make sure that we go over this again because we want type 3 or type 4. So when we're talking about type 1 and 2, that's when we think about it being way too hard. There's too much water sucked out of this poop. So you have the hard little rabbit pellets of type 1. That's how I will affectionately refer to them, your rabbit pellets. You have the sausage-like, lumpy, really hard stools, but are still together. Type 3 and 4 are the ones you want. That is our goal. Type 5 is starting to get mushy, it's starting to break apart. Type 6 is completely mushy. Type 7 is completely watery. Most people, if you ask them what type of stools do you have, they will have no idea. So you literally will print this out for a family and say, go home and look at your poop and come back for the next couple of days and tell me what kind of poop you have here. It was a proud auntie moment when my young niece was able to tell me her Bristol stool type. So I was like, I have succeeded as a pediatrician, and she knows this. Right? And that's helpful to be able to make diagnostic clarity. So when we're talking about this, maybe thinking the goal is 3 or 4. Right? What else is the goal? If we're trying to think we need to have correct defecation, what actually is that? Well, the type 3 or 4 is functionally a little bit more firm than peanut butter, probably, right? So you're trying to have a soft stool that takes no more than about 5 minutes and requires no straining or valsalvating daily, right? If people really think about that, most people are like, oh, so that's what normal is, huh? Right? You think about our Western diets, you think about our lifestyles, it's not most people on. So because it's not most adults, it doesn't translate really into what most normal children should be. Adults are thinking about what their own habits are and translating that down to children. So having a set of what is normal helps us even start with what is normal for a child. So for a child, about 5 5 minutes daily, that has no straining, and is a Bristol type 3 or 4, is where we're trying to go. Okay. What happens when we're not even close to that? Now we're in Bristol like 5, 6, 7. Okay, so we have functional diarrhea. So again, not to read you GI, but talking specifically about things that affect toddlers. So a toddler's diarrhea is a specific entity where they basically have, this is why pediatricians hate juice so much. What typically happens is they will intake high fructose corn syrup in large amounts to the point that they have overwhelmed the ability to absorb and digest the disaccharides. And because of that, it ends up just floating on out. And so they end up with the functional diarrhea. So how do you know it's functional and not pathologic? So this goes back to block 1, where we had our growth charts. So if you're looking at growth charts in a kid, the parent comes in and says, they have so much diarrhea all the time. And you're looking at the Bristol stool and it's a Bristol 6 or 7. How are you telling them, is this pathologic and I need to work them up for all the GI things? Or is this totally normal and I need to take a good dietary history? The big defining factor there is their growth charts. So functional diarrhea will have normal growth charts. The kid is otherwise growing well, happy, doing everything at the exact time frame they should be, but they are absorbing things correctly. So it's from that overwhelming of the disaccharide capacity. You could start thinking, yes, they have an infection. Do they have celiac? Is there some other thing going on? But most of the time it's going to be from this. You start asking, how much apple juice do you drink a day? And they're like, we go to Costco and buy 7 of those a week. And you're like, we found it, right? So something like that. It is painless. So that is another distinguishing factor. Is so these toddlers do not care one bit. It bothers the parents much more, and it bothers the purse strings because they go through a lot of diapers much more than it does any pain or bothersome to the child at all. It must last several weeks, so 4 weeks is the diagnostic criteria. Not as important because you can start to see this entity pretty early and you can intervene. No need to continue Costco-sized amounts of juice to make a diagnosis if you already know that's what's going on. And it should be between, it's missing a word there, number 3, between 6 months and 5 years. So you need to be in an age-appropriate time frame where you would be absorbing that large amount of juice in that capacity. And then again, no failure to thrive. So that's the biggest 2 would be, and the ones that I really want you to focus on are 1 and 4. It's painless, type 5, 6, or 7, and it does not affect their growth whatsoever. So the treatment is the best treatment ever. Take away the juice, which is a very, very hard thing to do. But we will talk about when do you actually want to use that juice for later things. Which gets us to the exact opposite problem in children. So when you are going to see adults, you're going to work them up for all kinds of abdominal things. Is it the gallbladder? Is it the pancreas, their liver, are they drinking too much? All this other stuff. In kids, belly pain is constipation. And then your second differential is constipation. And then your third differential is constipation. And your first 97 differentials are constipation until you finally get to something else. Okay, so when in doubt, clean it out, and then you can start down the rest of the workup. So that's what we're going to be talking about. So less than 2 a week, so we already said it's supposed to be daily, but if we're at less than 2 a week, we have met that. Or if we have those hard pellet-like, so really a Bristol type 1 functionally. Super common, we see it all the time, and we see it at big times of transition. So that first big transition was when they went from an all-liquid diet to starting to have solid intake. So around 6 months, there's a change. There's a change again once they are learning to respond to that gastrocolic reflex with toilet training. So it's big time 2. And then time 3 is a big transition where they're going to school. So suddenly now they're not just at a home or a daycare environment, they're in a structured learning type environment. So you see those 3 big times where the problem will often start. Doesn't mean that's the only time. We see it in school age children all the time. But those 3 transitions is usually when this time starts. Some of your history. So the classic history is going to be like anyone else, right? What do the stools look like using your Bristol stool cell? How many times a week is it occurring? But some of my other questions that I will specifically ask that aren't even in your book that I feel like I get a little bit more from families is how many unsuccessful attempts do you have? So that means a child's going to go and say, I have to poop. They go try and nothing happens. So that would be thing one. Thing two would be how many times does this little child clog a toilet? Thing three is how many times does the family say, oh my goodness, this is adult sized. How did this come out of your body? When you start seeing that. And then how often are they straining? So that is going to be another big sign. So yes, there will be sometimes some pain from the straining or some fissures going on, or other different medications that you're using. Iron is the classic one for being a constipating med. But I have found that the unsuccessful attempts and the large stool, adult life-size stools are a little bit more helpful in history than some of those classic ones. Your exam is not going to be particularly helpful always. Sometimes you can feel a large stool burden on that left compared to the right. However, if you're feeling a large mass, it might be something to work up a little bit further with that. And certainly if there's any kind of neurologic symptoms, or they cannot feel something, a saddle, paresthesia, that's a little bit more concerning. We're outside the realm of a functional constipation for these kiddos. These would be your red flags. So if you see any of these in a test type question for these kiddos, this should take out of your mind, oh my goodness, this is just functional constipation. So let me point you to a couple of ones that I really want to look at. So if that very first poop was not within that first 24 hours of life, the diagnostic criteria is 48, we're really thinking you should poop on day 1 of life. You should start proving that you can do all of these functions. I can eat, I can pee, I can poop. If you can't do that and you have a delayed meconium passage, it's going to be something that raises a red flag for Hirschsprung's disease right off the bat. If you have early constipation, so if you are a neonate that had true constipation, so not the dysfunction where your body and brain are trying to work together, but truly hard stools, it's another red flag. Certainly if somebody else in your family has it, so that's number 3. Blood in stools in the absence of fissures. So fissures, when you have those cracks, they're always going to have a little bit of blood, obviously, because you have a break in the skin. So, but if you do not have fissures and you have blood in your stool, that should be a red flag. And then failure to thrive. So if something is happening to the point where there is some sort of malabsorption component or something where you have very, very hard, greasy stools, difficulty with defecation, another big red flag, you should not have failure to thrive with this. With that, you start thinking, do I have a cystic fibrosis? Is something going on there? What else do I want you to? And then maybe the tuft of hair and sacral dimple for really that spina bifida. The rest of those should make some sense, or something you saw before in GI, but kind of pointing to those specifically for the pediatric population. The nice thing about this is because this is so common, we see this so predictably, functionally, there's not a big workup for this. So this is not one that you need to start poking the child, so no labs are standard here. And really, there's no radiology unless you have those red flag symptoms. So there's no standard, you don't need to do an ultrasound looking for poop, you don't need to do a radiology, an x-ray of any type. The times you would think about this is, oh my gosh, we really do have a family history of Hirschsprung, and we didn't have that meconium passage. I need to be thinking about Hirschsprung's. So in that case, that would be a biopsy. Or if I thought, there's something wrong here with the anatomy, so something isn't matching up, and I need to really look at the anatomical structure as opposed to the physiologic functional structure. So what's going to be first? So first is thinking, what are they eating? What's happening here? Are we getting Taco Bell 6 out of 7 days? Are we getting Whataburger 27 times a week? Or whatever the diet is there some sort of semblance of a normal or healthy diet? Again, very difficult with toddlers who will eat like chicken nuggets and Hot Pockets. Thing two is that there should never be any retaliatory or punishment associated with toilet training. So that is one area that can be very frustrating to parents while they're trying to potty train kiddos. So you have to decouple any kind of punishments with the defecation process. So it should never be a reason to get mad at a child. Lots of education. So the gastrocolic reflex is one of the most important reflexes. So what is functionally happening with that? You eat food, it sends a signal to the stomach, we got more coming. The stomach then sends the message, hey, we don't need to save this anymore to pull out any other nutrients, move it on out. And that should be the way this normal reflex goes. So about 15 to 30 minutes after eating or drinking, you should start feeling that gastrocolic reflex. Most people, over time, will start ignoring that reflex. You eat, I have a meeting, I have class, we gotta go, we're running late, we have soccer. So we'll start ignoring that reflex. And so really capitalizing on that with kiddos who are potty training is of the utmost importance to be able to maximize that. So we'll say typically after meals, go sit on the toilet for 5 to 10 minutes. See what they'll do with that. Right? Get that reflex working. So with that, a child is also, if you've ever been around a kid, they're very afraid of the toilet, right? Because it's big to them. Like think about like proportionate size. And then when it flushes, there's the amount of kids that are scared of the flush and like it's just gone and they're like, am I gonna get flushed away and be gone? There's a lot for a kid there. So one of the things that can be very helpful is to have something that is their size. So a small potty that is next to the large potty or the small seat can be very helpful for these kids too. One of the other things you have to decouple, not just with punishment and defecation, but pain and defecation. If something hurts a child, they will not do it. And so if it is hard stool that hurts, they will avoid this like the plague. And they will continue to avoid and continue to make that problem worse and worse. So the idea is to make the bowel movements as soft as possible and get it on the softer side first to decouple that pain process from it. Typically that will mean polyethylene glycol, what's that other word for that? Parallax, yeah, exactly. You can use milk of magnesia, mineral oil, you can use all kinds of stuff, but most of the time we're going to use polyethylene glycol. Parallax is our go-to, so I'll refer to it as that, or PEG from now on. So what are we going to do for a clean out? So when we say we got to clean them out, right? They've gotten so backed up that we really got to move all of this poop out of the GI tract. So who are we going to do that for? Well, one, if they have that history of it. So anybody who's got some abdominal pain that's kind of non-specific like that, no red flag symptoms, it comes after eating, they talk about stomach pain in the mornings, any kind of thing like that. And they're tolerating PO, so they have to be able to drink to be able to do this. And then no evidence that it's going to come right back up, because that wouldn't be very helpful. If we have a PO treatment, that's going to come right back up. The idea is that you have to tsunami this, right? So if you just have a little bit at a time, you take one little capful of Miralax, that might be fine to get the very end out, but you have a whole colon full of poop. So you need to functionally tsunami this to get everything to come out. So you're functionally bowel prepping them like you would for a colonoscopy to reset this gut. And so when parents will hear how much you're going to use, oftentimes they will look at you with really big eyes. I worked with a PED GI who had 2 settings. Said you will take half the bottle of Miralax if you are under the age of 5, or the whole bottle of Miralax if you are over the age of 5. And that was a lot of Miralax, right? Those families didn't leave the home for several days after that. So I personally will back it down a little bit. He said I'd rather get it all out and then not have to play catching with our tails. So most of the time we'll say do this over a weekend where you have a lot of time to get everything out and to reset these little kiddos' gut. So Friday night is the ideal time if you're going to do this. I usually will use their age plus 1 or 2 catfuls. So if you have a 5-year-old, we're going to use 6 to 7 catfuls. Mix it with something that they enjoy drinking. Ideally not milk, will crystallize in milk and it is disgusting. But an apple juice is a great example. Gatorade. If you talk to your patients about Gatorade, make sure you understand what color of Gatorade they're using. Red Gatorade, when it comes out, looks like blood. If they throw it up, it looks like blood. It's very scary to parents. So be aware of what color Gatorade you're going to use if you're doing that. And the idea is to get in as much as possible because we're trying to again, tsunami everything out. So you can do this where they're taking as much in over the course of a couple of hours, or you can do an ounce at a time, 1 ounce every hour until they can get the whole amount down. How much liquid do you need? You need enough to dissolve the Miralax. So however much that's going to take. On our end, we'll say let's start with 24 ounces. If we need to go up to 32, 28, we can do that. This will start about 8 hours after. Everything will start to kind of move. You'll have some stomach cramping because their body is not absorbing that liquid. It is all staying in the gut. And because of that, it's going to feel very cranky and uncomfortable to the child. That's normal. Should not be painful, but it is often uncomfortable. We'll say stay at home after that to make sure they are near a toilet to allow everything to come out. The idea is that at the end of this, it should be running clear or clear yellow because there is still some stercobilinogen that is causing from the hemoglobin breakdown, so you still should see some color in that. So it kind of looks like another weird Gatorade. What about inpatient? So some kids, it is so bad, they need inpatient for this. So who is that kid going to be? Well, this is going to be the severe abdominal pain. When I say severe, I mean, you know it's not peritonitis, but they can't go to school, they cannot function. It has been 10 days, 2 weeks since they've had any kind of bowel movement. So severe abdominal pain. They will not or cannot take any type of PO, or they are vomiting. So certainly they cannot hold anything down. If you're going to do inpatient, you need to go from both ends. So you need to get the plug from the bottom removed to get things going, and you need to have it going from the top. So if they can drink, that's great. If not, then an NG tube to help remove that out. Again, we'll be using polyethylene glycol. You can use that. You can use Go Lightly as well as another option to help things get moving. Making sure that, again, everything is going until everything is clear. So what's going in is functionally clear as what is coming out. So this is not an infrequent admission, I'm going to say, because it is that common for kiddos. Now what's happened? So now the gut has gotten so big over time, it is stretched to accommodate all of this stool. And so the reason they need to be on maintenance dose after is it took a long time to get that big. It's going to take that long to return back to size. If you don't continue to keep the stool soft and you just have a big gut, that's just going to accumulate and you're going to have the same problem in 6 months, or you're going to have the same problem in a year. They're going to come back and say, well, we did that GI clean out and it didn't work. And you're like, well, it did. It just reaccumulated. So the maintenance dosing is to allow that gut to go right back to size, to a normal amount of stool for this child. So typically this will mean that you are going to calibrate the Miralax to make sure they have that one soft stool with no straining every day. So how much does that mean that that child is going to need? How much is that kid going to need? We have no idea. I have no idea what that kid's gut is going to need. Does that kid need 1 capful every single day? Maybe. Do they need a half a capful every other day? Maybe. Do they need 2 capfuls twice a week and a capful every day? It's whatever the family does to be able to have that Bristol 3-4 with no straining and no pain. So that's where the education for your families is super important. So they know what the goal is, what's normal, what's our objective, and then how to titrate that Miralax up and down to make sure that they accomplish that amount. Most common thing that we see of these recurrent episodes is that they will say, the stools are good, we're good, we don't need to do this anymore. And again, that big gut is there and just reaccumulated. Yes, ma'am.
Is this, the maintenance, is it for outpatient and inpatient cleanup?
For any constipation. Yep. So after you've done the clean out, if it was inpatient, you start maintenance. If it's outpatient, you start maintenance. Good question. So what happens if it was such severe constipation, so severe, or long-standing constipation? Now you get into the entity of encopresis. So it is functionally constipation that went insane. So it is still on that same spectrum, but now we have an entity where it looks like diarrhea, but it's actually severe, severe constipation. And this throws providers and families alike off. They will come in and they will say, we need something for this diarrhea. They're staining their underwear, they have problems at school, they're leaking, we need to do something for this diarrhea. And you start taking a history, and you do a physical exam, and it is actually very, very, very severe constipation. You're trying to explain to this family why you need to treat their constipation, and they're looking at you like, where in the heck did you go to school? Because it does not make sense to them fundamentally. So when you've gotten it to be so compact and so hard that nothing is moving, the gut will continue to expand, and it will continue to say, I gotta get something out. And so now they will have truly liquid stool that is going around the hard stool and is coming out liquid. And because everything has gotten stretched so much, they cannot feel this anymore, and so it functionally looks like leaking or diarrhea to a family, but it is very, very severe constipation in this kid. So usually about 3 months that it's been going on, and it's over the age of 4. The reason that it's over the age of 4 is that up to that point, there is really still some wiggle room of, are you fully potty trained? Is this really developmentally where you are or not? After the age of 4, you should be able to be toilet trained during the day, especially, and at night. And so at that point, no longer really a developmental concern unless there's some other concerns going on. And so in that setting, that is why you know that from the age. The child is often, because they're developmentally at an age where they're a little bit older for this, they're often aware of this and they will deny. So that would be one of the things the boards love to say, mom cannot find his underwear. Or there's, he came home missing underwear or something like that. If you see missing underwear, it's usually a sign that they're going for encopresis, something like that. And they will usually give you that there's something else going on. So they might have had that functional constipation, they started kindergarten, but now they're getting bullied, or now they PCS'd, or now something else happened that took what was a very normal functional constipation and amped it up. So some indication something happens there. Most of these kids, if you're doing an exam, as opposed to regular constipation where you really might not feel anything, these kids, you can often feel very, very hard stool balls. I think the most epic one that it just stays in my brain. This child, feeling down the left side of the colon, felt like he had swallowed golf balls, and they were just these hard golf ball size all the way down the left side. And so it can be very, very astounding on physical exam when you're really used to not feeling much. Often they will have anal fissures as well from severe straining and very, very hard stools, so those can go together as well. And again, this would be the child that certainly has a higher suspicion that maybe something neurologic is going on, because this is certainly more rare than the functional constipation. Because it's on that same spectrum though, your workup looks very similar. So there really is no lab that you need to do. So really for any kind of constipation in a child that is this functional type, no labs. If you're getting radiographs, the reason to get radiographs would be a couple of things. Number one, to see how far backed up truly are they. And number two, if the parents are looking at you like, you've lost your mind, it's not constipation, it is diarrhea, this is a way to help kind of get on the same page with that family. I will say, if you order a KUB, if you order one plain film of this, and you do not specifically ask the radiologist to comment on the stool burden, they will not. So that has to be, dear radiologist, please comment on the stool burden. Love Lindsay. So that would be how they would say, or in provider speak. But that can be very, very helpful. When you're looking at the x-ray for stool, any kind of places along the way that almost look fluffy, kind of cloud-like. And so you can kind of follow it all the way around and you can kind of see that colon and how far backed up this is. So a lot of times we'll say, this child is FOS. Right? And this is a perfect example of that. Full of stool. Same work up there. So your goal, because it is that same spectrum, is very aggressive treatment of that constipation. So this might be that child that was outpatient and now you're going to do inpatient to get them completely cleaned out. Or you might have done, say they're 5, you might have done 7 capfuls. This might be the child that you do 15 capfuls, something a little bit more aggressive to make sure that you get all of that hardened stool out of there. This one will often need rectal help as well with some different enemas to get things moving, to get that blood moving. So even at an outpatient level, this might mean that they need some prorectum treatment. Again, you have to decouple that pain from the stool. So one of the biggest things there. For the families as well, there's going to be some lifestyle and behavior modifications, listening to that gastropolic reflex. So trying to make sure there's time after meals, or in the mornings or before bed. And then often reward systems will work for these kiddos as well. And a lot of praise will do this as well. Fluids, fiber, all the things that you learned from GI are going to apply to children as well. So a lot of movement, fiber, liquids, decreasing things, if you can, iron, dairy, will be very, very helpful. Okay, a couple of things. So all of this stuff you've learned then in GI, these are the application again for the kiddos. So you learned constipation, you learned encopresis, how is that going to present in kids? This is very similar. So celiac, you've probably seen this up and down, you're like, GI, we've seen it all, endo, GI, yeah. A couple of things, the way I've seen it on boards is they will just put non-tropical screw, or they'll call it the enteropathy, so they'll call it something different just to throw you off. So be aware of both of the different names there. As a reminder, we're talking about gluten sensitivity and what that is and what it's seen in. We'll kind of tie back to thinking about block 1. Who do we see this in? It's usually kids that have something else autoimmune going on or something else genetic going on. So remember, this was one of the things that we looked for in those annual evaluations for kiddos with trisomy 21, was celiac. That was one of the things we looked at. If you have a child who, and we'll talk about it in block 3, has diabetes, this is another one. You think, I had one autoimmune, am I at risk for a second? So there, it's going to go to diabetes, specifically in these kiddos. And again, thyroid, because thyroid goes with everything in kiddos. Can start at any age. So you're like, well, can a 6-month-old have this? Yeah, it's a little bit more rare. Can a 2-year-old have this? Yep. Well, what if it didn't start till they were 16? Yep. You can see it at any age when it starts presenting. And really what I want to, again, draw your attention to, because the other stuff you've already learned about, the biggest difference in how it's going to present here in a child is two things. One, severe fatigue in a child. You don't often see kiddos that are just fatigued. These kids are just tired. They're not getting any nutrients. The other one is failure to thrive. So if you see a kid and the parents are like, I swear to you, we're feeding this kid, they have a great food journal, they have all the snacks, they're just pulling out the Cheerios and all the things, and then, but they're still on their growth charts, failure to thrive, this should be one of those top diagnoses. The rest of this, you guys have already seen that. It's the same stuff for the adults. Things to also think about with kids is if they have the extra manifestations. So you wouldn't really expect to see osteopenia in a child. We haven't really ever brought up things of like a child's joints are hurting, arthritis, arthralgias. That's not normal for children. So if they are presenting with some of those type of symptoms, this is something to think about. Certainly ataxia and liver involvement is going to be on the severe side. So it's either a very severe presentation or it's been going on a while. But all of those extra manifestations are ways that you will see this present that might not be the classic ways of abdominal pain and some discomfort with eating that you would see in the adult world. Okay, so compare that up with failure to thrive particularly. as one of those things that you see in kiddos. As a reminder, if you're going to diagnose this, they have to be eating gluten. So you have to be making antibodies against the gluten, that protein. So if you're on a gluten-free diet for enough time, you will not have those antibodies in sufficient quantities, and so we will get a false negative. So the family should be eating gluten at the time. And when you're drawing this, you are drawing the two different antibodies that would be against that. So anti-endomycel and anti-TTG, so those are your two. But you also have to have the control. You have to know what their total IgA is. If you don't have a total IgA, and you know that they make any IgA, then their antibodies can come back negative and it means nothing. So you have to know, do you make IgA? And if you do, then do you have these antibodies? As a reminder, IgA comes from mucosal cells. That's why it's in the gut. This is not an IgG like we're typically used to seeing. On those mucosal surfaces, this is an IgA. If you have those positive, then that would be the child that you send to GI for an endoscopy. So this would not be a child at a PCM level where you're saying, child has abdominal pain and failure to thrive, please work up. This would be, you have made sure that they have done a gluten-full diet, you have gotten the IgA total, you've gotten the antibodies, IgA antibodies. When you're out, these are one of the things that will come in a panel, so you can, when you're inside of MHS Genesis, you'll see celiac panel, click. If you order a panel, just know what's on the panel. So this one does have the IgA, but when it first came out in Genesis, it didn't have the total IgA. So we had a lot of things where we were having to redraw people. So just a note on those panels. If it's positive from your endoscopy, then it's a lifelong avoidance of gluten. Same for the adults. This is another one of my pet peeves. It's allergic colitis. If you think allergic colitis, what kind of antibodies do you think of when you hear allergic? IgE, yeah, and these are not. So this one drives me nuts. It should be called immune-related colitis. So it's a way that I want you to think about it. So it's going to be called allergic colitis or milk protein allergy, but it is not an IgE response. So you could think of this as a milk protein immune-related response. That doesn't sound like the same. So for some reason, a child, when they are first born, a neonate, has trouble breaking down the proteins in both milk and soy. So they cannot do this, thus it ends up breaking down the mucosa in their gut. It causes an inflammatory response, and they end up, although they're able to absorb it, very hard on the gut, and it comes out with bloody stools. So think about this. You have your precious new baby. This is your first time you open the diaper and you see blood. Freak out, panic, right? And then you come see a PCM or a pediatrician, we're like, oh, that's no problem. It's a milk protein allergy. They're gonna outgrow this. And now you have freaked out families. That's why several of us don't like this. It's really an immune-related response while the baby's gut is still too immature to be able to break down the protein correctly, thus creating that inflammatory response and having bloody stools. So not my favorite nomenclature there, but that's really what's going on. Is a colitis, we call it termed an allergy, from this protein breakdown. It's less common in breastfed infants. That protein from mom is a little bit easier to digest. And really the only thing you see is these bloody stools, and it bothers the parents 1,000 times more than the baby. Baby does not care. Baby's still eating, baby's pooping, baby's playing, baby's happy. Parents completely freaked out. So what are you going to do for this kid? I usually will check his CBC to make sure how much blood are we losing here, and checking, is this actually blood? Okay. Is this a young family that's giving raspberries or something going on here? And then if we're trying to treat, and mom really wants to breastfeed, we'll have mom take as much of milk and soy out of her diet so that the baby is having less of that transfer. And if the baby is on a protein, we're going to, back from block 1, we're going to use that partially hydrolyzed formula so that the protein is already partially digested. It's a little bit easier on the child's gut. Do the process for them. Okay. My favorite one to start with is Nutramigen. So I put it on here. Nutramigen, it's the orange can, and it's a partially hydrolyzed formula. So the baby's still going to do some of the work in the gut, but it's partially hydrolyzed. Alimentum is a fully hydrolyzed, so it's basically an amino acid formula. So everything's already broken down, and that's why it smells so bad, and that's why it's so expensive. So just if you see that, it's in the purple can. Couple of words on AGE for kiddos. So you guys have probably talked about that also till you're blue in the face. So now you have the same stuff as the adults. Now you have diarrhea, vomiting, something else going on, plus or minus fever, their stuff, their tummy's hurt, they feel nauseous. So it's the same exact presentation for this as for the kiddos. The problem is kiddos spread this super easy with daycare and with school, and they dehydrate a whole lot faster than the adults do. So that's your biggest consideration there is the level of hydration for this kid. And how sick do they look? So we're talking about different things with daycare, not daycare, that will come into play for a little bit. As a reminder back from GI, there were 2 different types of things to do when we're relating this to AGE and different types of diarrhea. So one of them is that osmotic pressure where functionally that water is coming into the lumen because of some amount that is unabsorbable. So if you were thinking about lactose intolerance, they're unable to break down because they do not have lactase, so more water is pulled into that lumen. It's the same functional way that Miralax works, really, where they're undigestible, so it keeps all of that liquid that they took with the Miralax. That's not really what we're talking about. We're talking about secretory, right, where you are having some sort of bacteria or viral entity that is causing them to transport more, thus they are ending up in a dehydrated state. More often with bacteria, you're going to see a bloody component, more likely with viral, a water component. Exactly what let's see. When you have viral, so this is what you'll see. I think we actually saw this a couple months ago, right here at iPad, right? So it starts with vomiting, and then it's going to work its way through the GI system, and you will typically see day 1 or 2 is vomiting, followed by diarrhea. The problem with that is when you have that diarrhea, it goes takes out those little microvilli, and so while those microvilli are growing back, they are still continuing to have that diarrhea. So it lasts much longer than the vomiting does, and that's typically what concerns parents, is they had this vomiting, now the diarrhea won't go away because the little microvilli are trying to grow back. That just takes a little while. So it should take less than 2 weeks, but that's a long time for a parent, especially if you're thinking all those diapers, discomfort, things like that. If you're thinking, if you had to guess, just epidemiologically wise, younger than infants, you're more likely going to see the rotavirus. So especially if they didn't get that. That was your one live oral vaccine, way back from block 1. And then if you take your kids on those cruise ships, norovirus, and boards love those. They just love to talk about cruise ships. It's always norovirus. Typically, it should be under a week. So if you get to the 2-week range, you're a little bit outside of what would be normal for kiddos. These are ones just to highlight that your boards love doing. They love these ones, right? So you need to be able to just recall them. So when you think salmonella, you need to think some sort of reptile or iguana. Iguana was on my boards, so just like a near iguana and salmonella. If you're thinking Campylobacter, the one that comes to mind should be some sort of chicken, right? It's the cheapest thing to feed kids at camp, is chicken. Okay. Shigella, you're going to think seizures, so Shake-ella. So if you see Shigella, that's going to go with seizures. Your 0157 is beef. Yersinia, good old plagues, the chitterlings. Lunch meat, that's one I've been seeing recently for listeria, and then shellfish for cholera. So those should be ones that you just very quickly come to mind because they test them the same way on pants every single time. This, I want you to star highlight all of this right here. C. diff. You guys have learned it all kinds of different ways. It is normal flora under 2. Super different. So if you have a child under 2 that comes into clinic and you're like, oh my god, they're positive for C. diff. Yeah, because it's their normal flora. So, super normal for kiddos. So unless you see a question with a kid and it tells you they've got Clinda and their entire family has infectious C. diff, it's normal flora. Okay? So highlight, star that. Somebody always misses that. Normal under the age of 2, normal flora. They can get the other parasites as well. So the most common one, the one that I really want you to highlight here is Giardia, because that one is going to happen in daycares all the time. So the other ones I'll leave over to GI and assume that you guys do that one. Kiddos, it's most likely going to be Giardia. Most of the time you're not going to need labs. So this is the really nice part about a lot of this stuff for GI. Most of the time you're not needing labs. The ones to think about, who am I going to get labs for? Do I have bloody diarrhea? Are they truly febrile in this illness? Is it prolonged, meaning more than 2 weeks? And how significant is their dehydration? If it is so significant that I am worried about them going home, I need to know what their electrolytes are. It's really who you're going to be getting labs at. Actually, that's exactly what it says. The other things to think about, if you have that fever or if you have truly bloody presentation, is the rest of your stool workup. So how many white cells, the fecal leukocytes, do we have, is my immune system ramped up in the stools? Am I going to culture it? Am I going to be able to see what kind of bacteria is in there? Am I going to get any O and P, ova and parasites there? C. diff, if they're over the age of 2, so it's just not normal flora. And then any kind of testing that you would do for mucus blood could do rotavirus if it was in that right. But really what I want you to only see is your culture, your O and P, your fecal leukocytes is for fever, severe or over 2 weeks. So I know that 2-week mark. Close. Actually, let's take a break here, come back at the top of the hour, and then we'll really talk about dehydration. You guys look like you need a little break.
Now you just have to keep Cooper.
So for, I don't fully understand. So when I put it for, you know, say you have to take water to So really, as long as you get to do it, back in school, whether that's capful, all the capfuls, as much water as it's
That's me.
No, I'll say I will get that into you. Every question they ask me, I'll do that.
Do you want to see it? I don't know. Push up to class. Yeah, if you want to go back and do it.
Did you find the net? Yeah. Yeah, like right across from the mailroom or something. Yeah, Alan and I just walked down and she's like, Mom.
Yeah, I won't have ask me how to look at it from a student's perspective. I want to understand how it works, but also I want to understand
antibodies. M is the smallest. Not that it matters.
Still have infectious C. diff. If they're under 2, if they're having those clinical signs and symptoms. However, if you were just doing a workup for diarrhea and got C. diff and they didn't have that clinical picture and antibiotic use, it would be positive, and then that's not helpful. Okay? So if I give you something, I'm like, this 18-month-old has had multiple antibiotics, something like that, like still, but I'm not going to do that too. That was question 1. Question 2, for celiac, it is a blood draw. So that one's going to be something you will draw from the kiddos. And then just a word for tomorrow. I know this has nothing to do with PEDS, but a couple of helpful hints from over the last semesters with the thesis presentations. In general, make sure you answer your question, right? So if your data has a little bit of this and a little bit of that, and answer the question, because functionally this is a clinical inquiry. If we're talking amongst providers and I have 3 minutes in between patients and I come ask you, I need to go into this patient's room, what is your answer? So answer the question, be able to know what your limitations were. If your question didn't look at XYZ and that's what you get asked about, it's totally okay to tell us that's not my clinical inquiry, that's a different inquiry, right? Don't let us throw you off like that. And then know your papers well. Like what was in, what did they look at, what did they not look at, some of the things. If you say something or you put something on a slide, make sure you can defend that. But ultimately answer the question that you asked. Like pick a side. Biggest hints for tomorrow. But back to AGE. So we're talking about the kiddos and dehydration. So the biggest question, the only question that should matter for children, can they tolerate PO? If they can tolerate PO, use their gut. Just pretty much period, if they can do that. So things that you're going to look at, yes, you're going to look at all of their vital signs. So their heart rate particularly will be very sensitive. So if you just have a kiddo whose heart rate is high and they're just sitting there chilling out, you should think to yourself, what's going on? Right, so that should be the first one that's going to go. How much are they taking in? How many wet diapers? What's their skin turgor like? Are they still making tears? So a little bit different questioning for those babies to think about. As with some of the things that we've done before, if you think back to like Apgar, look at your severe, look at your mild, and know those two, and what's not bad is going to be in the middle. So if we're looking at mild dehydration, the kiddos are still up and alert. They might be a little thirsty. They might not be wanting to drink, but they can. Their pulses, the rest of their vitals, normal or slightly off, and then the rest of their exam is very normal. Okay, so they still might be dehydrated when you're taking a history of that wet diaper and really their oral intake. They're doing well. As opposed to super severe, where they are truly lethargic or obtunded. They cannot, they're unstable, their vitals are absolutely a mess, weak, thready, deep, sunken, their skin turgor is terrible, they're cold and mottled, right? You should be able to see there's a large difference between that. What's in the middle is really functionally what happens most of the time when you're looking at that. Where it's normal or decreased, it's kind of in the middle. So learn the mild, learn the severe, anything else in the middle is what's going to be considered moderate output. Certainly, just like any other human, you need to make sure you correct their dehydration and you correct their electrolytes. And the gut does that for you. So the gut is going to do that. So if they can use their gut, please use their gut. So PO or not, that is the question. If you're looking at this and they have mild, the one we looked at, mild to moderate dehydration, please orally rehydrate. If it's on that moderate or severe side, that's when you start thinking IV. So a couple things with IV rehydration. Number one, this is a true procedure for a child. So if you're thinking as an adult, you're just gonna if you guys have been medics before or been in the hospital, and you're like, hey, you want a bag of fluid, you want a banana bag, right? To a kid, where you're putting an IV in, this is like an exorcism, and we're like holding them down and like octopus hands and arms, right? So if you're really thinking, do I want to do this procedure on a child? It also, you're messing with their electrolytes. And so it really matters when you have such a small body. So do I really want to do this procedure or not? This happens every semester, so we'll see if this is the first one that will happen or not. Somebody will say, well, it says mild or moderate twice. Moderate is on there for both IV and oral. Yes, absolutely it is. That is where your provider brain needs to come into play. If they are moderately dehydrated, can they tolerate it? Can they not? Do you think they're more moderate to severe or more mild to moderate? So that moderate is for you to decide as the provider which way are they going to go. What I don't need you to do, please do not memorize this table at all. What I'm trying to show you is that there are different concentrations for different liquids. So it depends on what you're trying to do. So if you are really saying, I need to do oral rehydration, I need sodium, then certainly Pedialyte is going to be much better than apple juice or Gatorade. If you are trying to say, wow, osmolarity-wise, I really need to get this kid moving, looking at that, oh, apple juice is the way to go. You're thinking, I am on a humanitarian mission, and I just need to get this kid pumped full of as many electrolytes as possible, I need to use the WHO solution. Functionally, what I'll tell families to do at home, if the kid really won't take Pedialyte, some people can taste all of that salt, is to use Gatorade, but mix in like 1/8 of a teaspoon of salt into that, and functionally you'll be very close to that same sodium level. So again, please don't memorize this table, just be aware of how much for oral rehydration you are giving your child, if you're giving them Pedialyte versus Gatorade versus apple juice. If you're doing IV rehydration, you are going to use normal saline. So it will say normal saline or LR. Really functionally, I can count on one hand, unless a surgeon specifically is yelling at me to give them LR, I'm giving them normal saline. So functionally, for kiddos, we are bolusing with normal saline. And you will need to know the dose. So 20 milliliters per kilogram for a bolus for a child. Unless they are under that 1 month of age and they're a neonate, then you're going to start with 10. So each bolus is then going to be 10 for them. It's not like the adults either, where you can just set this and walk away and let it drip in. You need to set it over a time period. You do not want to give them fluids too fast. So you're going to give a bolus over 20 minutes. So your nurses will usually set your pumps for that, unless you're doing a massive resuscitation protocol. So this is just regular old dehydration here. And you can repeat these boluses, checking in between each one up to 3 times. So functionally you have a 3 strikes you're out rule. So if you are still not good to go at 3, you've bought yourself an admission for an overnight rehydration. Other things you can do, they are little humans, so you can still use your ondansetron or Zofran. One of the things I have seen people do is they will give liquid Zofran and then the child throws up. You're like, well, yes, you're giving it to them so that they will not throw up, but you just give them something that tastes terrible that they are going to throw up. So the recommendation for kiddos is to use the ODT, oral dissolving tablets, that can just dissolve in their mouth and very, very fast onset. The other thing that you will have to order when you are in a clinical setting is you will often order a PO challenge. So you'll order an ODT to help with the nausea and vomiting with an oral challenge, but they have to be time separated. I cannot tell you the amount of times somebody goes to do the orders and they'll give them the ODT followed by their PO challenge and then they throw up. And you're like, yes, that's exactly what's going to happen. So usually 30 minutes in between to help make sure that they can actually hold down the oral fluids that you're giving them. Antidiarrheal agents. I disagree strongly with your book. I've been in practice for 12 years and I have never one time given an antidiarrheal agent to a child. Never one time. So it is still indicated, however, it can cause toxic megacolon. Big old problem there, and if they have O157H7, you can end up leading to hemolytic uremic syndrome. So the risks, benefits for a child really just are not there. So be very, very, very cautious if you are ever going to use an antidiarrheal agent in a child. Antibiotics. Again, you're going to give these, so for those severe cases, meaning I got admitted for something. Something is prolonged over 2 weeks. there is fever, there is blood, something's happening there. Or there's a big outbreak and we want to sequester that down. So Shigella, what was that factor about Shigella? Seizures, yep. So if you see this, it's typically in that daycare setting. So it'll give you something, this 3-year-old is a perfectly healthy 3-year-old, never had any medical history. They had a seizure and everyone's been sick at clinic. What are you going, or sick or in that area, daycare, what are you going to treat with? And your answer will be azithromycin. Stop that outbreak. This is not a seizure disorder. This is an outbreak of Shigella. If you have salmonella, so those pet iguanas that you see there going on, and you have specifically under the 3-month of age, or you have an immunocompromised child, then you're going to treat with azithromycin. And then back to the question of C. diff, if you truly do have symptoms of this going on, metronidazole is your first go-to in kiddos. It can be a little bit different than the adults. You're still doing metronidazole first. Oral vape is your second one. As a reminder, just those differences typically, and for what you guys will need to know here, the fever and blood are typically going to go with your bacterial causes. Thinking, is this a judicious use of antibiotics? Is this one of those few that we've talked about, Salmonella, Shigella, C. diff type outcomes? Most of the time, they're going to recover beautifully on their own as long as they stay hydrated. Your chronic then is if it's over how long? 2 weeks. Yep, 2 weeks of whatever's going on here. So is this something from those microvilli, so the absorption isn't there? Is this something that has been long-standing? Is this a celiac? Is this an inflammatory bowel disease? One of the, it's happened a couple times. I had a family that I think I put the fear of God into them for their constipation, and they came back with chronic diarrhea like a year later, and they're like, we never stopped from Miralax. And then I felt really bad. So you do have, most of them, they won't do that, but a few will. So they'll come in with chronic diarrhea, and they're like, have you done the 2 capsules of Miralax every day for a year? And you're like, oh gosh. So just be careful. Make sure you educate your patients on both ways. And then is there any kind of other motility problem? Things to think about, this can happen as well for kiddos. So do I have that disaccharide deficiency, right? Did I overwhelm that with the toddler's diarrhea, with all the apple juice going on? Or do I truly have a lactase deficiency and I have a lactose intolerance in this child? Do I have a lipase deficiency? So this would be the kid that has, you see greasy stools, you see failure to thrive, you see frequent respiratory infections. That child has cystic fibrosis. And the gut manifestation will be that lipase deficiency. Do I have that milk protein allergy? So like that immune-mediated gut colitis going on? And then is it some sort of chronic infection? They went camping there at daycare with some of the Giardia things. Or are they truly losing weight as an older kid, bloody stools, and you're really thinking more of an IBD picture? So that is a little bit more of the specialty stuff to think about. So you might be doing the basic workup. GI is really going to start looking at most of these. Your history and physical then should really be looking, are they growing or not? So same as block 1, start of block 1. Are they growing or are they not? That is your biggest question that you are going to ask every single time. And then what else is going on? Most of the gut stuff is a manifestation with something else. So is it their growth? Is it their joints? Is it their stools? Is it something else? What else goes with it? Because you can piece those together. Your basic workup then, a PCM's basic workup. What are you going to do for these kiddos? Well, number 1, I want to make sure that they're not anemic. We don't have an inflammatory response going on. So my CBC. Are my electrolytes still okay? Is my glucose okay? Are my liver still okay? So my CMP, check to make sure that is part of the GI system. If it's chronic, is it one of those ova and parasites? Can I get anything at the stool pH or reducing substances? So do I have something that is not being digested appropriately and I'm seeing those large quantities of that? And then celiac. if you'd rather go to one at a PCM level. That should be the workup that you do before you send them to GI. So that at least is what you need to know. It's very similar to before you send somebody for a fever of unknown origin, what was that workup? It's very similar here. What is the workup that needs to be done before you just pump them over to GI? This is what you're going. When they say, why am I going over there? Likely because they are the ones that will be doing any kind of endoscopies or colonoscopies. And then just a quick word, kids eat stuff, kids eat all kinds of stuff. And so this is when you see they will probably appear to you guys as the adult providers that they probably started eating it in my world, right? So are they eating dirt? Are they eating hair? Are they eating gum? Are they eating all kinds of things? So a lot of times you do see this with some mental health or trichotillomania type presentation, or something to think about if you have a child who has got some weird abdominal pain, starting to ask about pica, what else are they eating? Really not gonna, please don't spend time working about the different type of bezoars. It's more of a history type question. Are you noticing that they're eating some undigestible source? And quick look at what that looks like. But I will leave that for surgery. Questions, comments about this before we jump into G